This lesson covers Chapter 1 in your Principles of Healthcare Reimbursement textbook. I strongly recommend that each and every week you read the chapter in its entirety and also become familiar with every key term that is listed on the first page at the start of every chapter. That will really help the material sink in and will help you when you do the homework that is set up in a quiz format. The U.S. healthcare reimbursement system is really extremely complex. If you watch the news at all, you probably hear talk about healthcare reform and the increasing costs of healthcare in the U.S. In this class, you will learn about the multiple reimbursement systems that really are in play in the U.S. today. And first, we'll start in this chapter with just defining a few of the basic terms that relate to healthcare reimbursement. Some of them you may be familiar with, but if not, these are some new terms or a refresher. Health insurance is defined as reducing a person's risk of loss. This is really just a generic term that applies to all insurance, whether that be your home insurance, your auto insurance, and your, obviously, in this case, health insurance. So this is relating to ensuring your health. If you've gone to the doctor anytime recently, when you received the bill, you were probably quite surprised at the cost. I know that I am every time I get a bill, especially for office visits. Those are increasing every day, it seems. So what health insurance does is help us pay and offset some of those costs, especially in the case of a car accident or cancer, something where the costs are really astronomical. That is really where health insurance comes into play to help cover some of those. But as most of you probably know, the cost of having health insurance, that premium that we pay generally every month, is very, very expensive, and that's getting to be so expensive, many people are having to drop their insurance. Many businesses are not offering that anymore because it's expensive to them as well. The premium, that's the amount that you pay to have health insurance coverage. Generally, it's paid monthly, but it can be paid in other formats as well, maybe every 6 months, something like that. Healthcare insurance has really been around for a lot longer than one may think. The first insurance was really introduced accidentally, and that was in 1847. Health insurance did not become really established until 1929 when Blue Cross, they were the first to cover school teachers in the state of Texas. And then in 1932, a plan was implemented in Sacramento, California. So as you can see, health insurance has been around a long time and obviously has evolved each and every year as we go. For many people, your insurance is tied to your employment, and many people work just to have health insurance coverage, and the fear of losing one's job is always there as a part of that. In most health insurance plans, in the reimbursement world, you go to the doctor or the hospital and you have your service, and then you pay for the service. So that's unlike a car loan, that kind of thing. But basically, as we know in modern U.S. medicine, we have the services and then we are billed and pay for the services after the fact. When thinking about healthcare reimbursement, it's very important to know the three different parties that are involved. The first party is you or the patient themselves. The second party would be whoever provided the service, so the provider, whether that be the clinic, the doctor's office, the nursing home. That is the second party. The third party is the insurance company or any other payer for those services. So that's really how insurance companies became the term third-party payers. There are three main characteristics of reimbursement methodologies, which are listed on this slide. They are unit of payment, time, orientation, and degree of financial risk. In this chapter 1, we'll talk about really the two major types of reimbursement methodologies that are in place in the U.S. today. And I think if you have insurance or have had insurance, these concepts will really start to sound familiar. The fee-for-service reimbursement, that's really when a healthcare payment where the providers receive payment for each service that is rendered. So if you think you have a service, there is a fee generated for that particular service. This table is also listed in your textbook, but this is really what I love as a summary of these two, comparing side by side. The episode of care side is more often seen in HMOs. Generally, the fee-for-service is your everyday health insurance that you may get through your employer, your Blue Cross plans. Those basically, you are going to the doctor and there's a charge generated on the claim form and there's a payment made. Episode of care, some of these terms we'll talk about more as we get into the textbook, so won't go too far. But basically, a lot of those are prospective payments, so they are negotiated ahead of the time, not dependent on an actual service being rendered. Some terms associated with the fee-for-service reimbursement, again, these are probably common sense or things that you've seen in the past, but just a quick summary. A fee is defined as the set amount or the set price. So a fee-for-service means a specific payment is made for each service that is provided. A charge is generated from each and every service that is provided, whether that's the doctor examining you, the nurse injecting you with a vaccine, sutures, any of those kinds of things. Basically, your coding comes into play and generates a charge for each and every procedure code that's assigned. The claim, that is what's sent to the third-party payer. And again, remember, the third-party payer, that is your health insurance company. So the claim lists all the services that were provided and what the charge is associated with each. The advantages are that generally people with the fee-for-service have the freedom to choose the doctors, the hospitals that they would like to seek services through. Disadvantage, there's often higher deductibles and there is co-payments that are generally on that type of reimbursement. Self-pay is just as it sounds. You as the patient or the guarantor, the one that is responsible for the account. Generally that's parents if it's a child. So the guarantor then pays for the services themselves, generally out of their own pocket. Fee-for-service, again, it's just as it sounds. You go to the doctor, have a service, a fee is generated. Some terms here, the fee schedule, that's just basically a predetermined list that's generally determined every year and adjusted every year. So it's a list of fees that the insurance company will allow payment for healthcare services. The allowable fee represents the average or the maximum amount that that insurance company or third-party payer will reimburse. So the fee schedule is the hospital will have a fee schedule and also the insurance company. Generally, they don't match. If you have received an explanation of benefits from your insurance company or an EOB that says it exceeded the allowable amount, generally the hospitals and doctor offices are charging more per CPT code than what is allowable. So depending upon the insurance company, that may be written off and you as a patient not have to pay that, or you may have to pay that, just depending upon each and every insurance company. UCR, what that stands for is usual, customary, and reasonable. In reimbursement, we really have a lot of acronyms to remember. I know it's difficult. You may want to get a little tablet and make a cheat sheet of what those are. I think that would be helpful. And basically, this is defined as the provider in the provider's practice. Customary stands for community, and reasonable in that particular situation. CPR stands for customary, prevailing, and reasonable. And really those two, UCR and CPR, those kind of go hand in hand. Both of those methods are based on past claims, so fee for service. You've already gotten the service, and then a fee was generated. RVS, that stands for resource-based relative value, and this is a term that we are going to spend a lot of time on later in the textbook, so we won't get into that, but basically that is a fee for service as well. It just classifies the health services based on the cost, that really what did it cost to get that service, in terms of they look at effort, what are the medical practice's expenses, the cost of malpractice in that geographical area, that sort of thing. Some forms of managed care are fee-for-service, not all. We will spend an entire chapter on managed care. So just kind of an overview as we're in this first chapter. Some of the features of managed care include coordination and planning to see those specialists, really focus on educating patients, keeping you healthy, managing if you have a chronic disease like diabetes, teaching you how to manage those conditions to try and keep you out of the hospital and away from the doctor's office and keep you healthy. The purposes of managed care, there are really two purposes, and really they look at the management or control in reducing the cost of health care. So how much are they reimbursing? How can we really get that under control? There are many, many kinds of or forms of managed care. Again, we have a whole chapter on that. Some of the ones that you may have heard are HMOs and PPOs. Those we will get into in great detail later. The main criticism of managed care is that patients' choices are limited. They have contracted with hospitals, doctor offices on, they have determined the fee schedule, they have agreed on many, many different items, so they want you to go to those places to have services. So the criticism is that really the patient's choice is taken away. Episode of care reimbursement. This is a healthcare payment system where providers, doctors' offices, hospitals, they receive one lump sum for all the services that relate to that particular condition or disease. So the unit of payment is not the episode, or it's not the individual health services each time you go to the doctor. It's really looking at that comprehensive, say you are in for diabetes and you're having an attack and you require an admission to the hospital and then 5 follow-up visits as a result of an exacerbation. That would all be lumped together into one payment. Capitation is what we refer to as per member per month. So if a managed care organization has contracted with your physician's office and there is 20 members and they have contracted, just out of the pulling a number out of the air, $50 per member per month. So then we would times the agreed upon dollar amount, the $50, that's really low, but just as an example, the $50 times the 20 members. And the hospital or the doctor's office is going to get that set amount every month, the per member per month, no matter if the patient was not seen ever or if the patient was seen 30 times. Payment will be the same. If you think about really what that means, you can see what the advantages and disadvantages would be. The advantage is that they would like to keep patients healthy. They're not going to order excessive tests, require patients to come back. If really indeed they don't need to come back, they're not going to get any more money. And also, right along those same lines, if you think about it, that could be at a disadvantage to the patient. Maybe they really need those services, and the provider is trying to make an extra dollar and knows that they're costing way more than they have been allotted for that month, and they may hold back services. Hopefully not, but that may be a disadvantage. In the global payment method, this is where the third-party payer makes one combined payment to cover all of the services of multiple providers who are treating a single episode of care. If you remember what we talked about a few slides back. So this payment really consolidates, as it sounds, into a global or a combined payment. A block grant is a fixed amount of money that is given for a specific purpose. In the prospective payment method of episode of care, payment rates for services are established before those services are given for a specific amount of time. Those are based on averages. So the predetermined rates are based, like I said, on average levels of resources for certain types of healthcare services. So as you can imagine, since that's based ahead of time and they don't know the actual cost, they could lose money, they could make money. Their idea is that hopefully over time everything should even out. Per dime payment, which can also be called per day payment, this is a type of prospective. Pro means ahead of time. So retrospective is after, prospective is before. So this is before the services were rendered. So it's a prospective payment method where the third-party payer reimburses the provider a fixed rate for each day a member is hospitalized. Case-based payment, this is the type, again, of prospective payment where the third-party payer reimburses the provider a fixed, pre-established payment for each case. What's going to happen to the future of healthcare reimbursement? I don't think anyone quite has the magic answer to that. Again, if you've watched the news, you've probably heard a lot of discussion on what's been termed the Obamacare plan. We'll kind of look at that as we go through the class and some of the advantages and disadvantages. And everyone has their own unique and independent opinion of that. And some of the discussion boards will get into people's thoughts and opinions, and I hope that everyone can freely express that. And even though you have differing opinions, it's good to get another point of view as well and see what other people are thinking, and hopefully that won't turn into a big argument. Just keep an open mind, and remember everyone has their own opinion. So what's going to happen? Your book goes through some of these. We don't really know exactly what will happen, obviously, but you can read through that, and again, we'll be discussing some of those items later in the class.